Okay, so this one is relatively short, I hope. I'm assuming just because a lot of, if you haven't heard already, a lot of the surgery shelf ends up overlapping a lot with internal medicine. And so I tried to cover stuff that maybe wouldn't overlap as much, but then maybe some high yield stuff that would overlap. So there's a lot fewer slides, I think, than the last few. So we might be able to get through the whole thing actually. So last time, or the times we've done it before, we've done like a few practice questions and then like a differential diagnosis section, which is kind of read my mindy, but I feel like it helps me think about things in terms of groups and then kind of working through each thing in the group. And then the last thing is just like rapid review, just like super, I feel like factoids that could easily be there on the shelf. So go ahead and start. Oh, and also just feel free to shout out. For those of you who haven't been here before, just feel free to shout out if you have an answer, even if you may or may not think it's wrong, that's totally fine. It's most of these are read my mind, so they're not right or wrong if you get it quote unquote wrong. Okay. Let me minimize the camera so I can see the questions. Okay, so the first question here, a 32-year-old male presents shortly after an MVC in which he was an unrestrained passenger. Vitals upon arrival included blood pressure of 89/57 and a heart rate of 131. He's in severe abdominal pain with guarding and rebound tenderness present. Which of the following is the best next step in management? So we got IV fluids and observation. We have a FAST exam. We have a CT abdomen and pelvis. We have an exploratory laparotomy, and we have IV antibiotics and outpatient management. And keep in mind, the main reason, obviously some of these answers look very like they all could be right in real life, which they probably are, but this is geared towards like the way they test things on exams rather than real life. And so sometimes on exams, there's a few things you're like, well, we would do all of those in real life, but so keep that in mind if you are like confused. Somebody said B, C. Okay.
I think maybe D.
That was what I was going for. So let's go to the answer choice and then we'll talk about it. I think in real life, I think all three, B, C, and D could probably be true. But the reason I created it like this, I don't think they'll be this nitpicky on the shelf, but just in case, I wanted to like sort of address it. So I bolded the reasons why, so to speak. So if you think of the blood pressure and the heart rate, you would basically, that sort of hits that threshold of being unstable. And then the guarding and rebound sort of indicates peritonitis. So I have a little thing here. If you've looked at some of the UWorld flow charts, they have something sort of similar and it looks a little bit better visually. But the first thing you should do when you see these questions is really categorize people into hemodynamically unstable or stable. And we'll talk more about it in a second, but the way I always did it was, because you can say, well, there's like borderline. So what do you do if they're borderline? I just created cutoffs in my head and then used like what I saw in questions to create like, this is unstable. Everything below this is unstable. So I say in my head that 90/60 is what they're going to on a test consider like unstable, and a heart rate over 120, which we'll talk about why that is in a second. And so once you've done that, you follow a different tree than what if they were stable. So because there was guarding and rebound and rigidity, you just basically, that's just the test coding for peritonitis. And so if you have unstable plus peritonitis, you just do the XLAP. And in real life, right, I mean, you're going to the operating room, you're going to probably do scans anyways. And that's just kind of how the trauma bay works. But on an exam, they obviously want you to pick one thing. And so they're just trying to get you to recognize that there's two really bad things happening at the same time. So the most important thing they need is surgery, because you've already confirmed that they have fluid or blood leaking into their abdomen just by the physical signs. And so you can kind of go down this tree here. If they don't have peritonitis, then you go to the next step. So if they have, you're like, okay, let's do a FAST exam. Then you see free fluid, and then you again take them to the OR, because instead of via physical exam, you've now confirmed peritonitis or confirmed peritoneal damage basically via looking at on a scan. And then if you don't know or unsure in the setting of unstable, you kind of just do something else. So if resuscitate's an answer, you'd probably do that. But if they give you another scan that's more definitive, you could do a CT or the DPL, which is where you basically stick the needle and basically see if blood comes out of the peritoneal cavity. So that's all if they're unstable on the left. And then on the right is if they're stable. So the right is stable is basically, oh, they're in pain, but it's not that bad. Or their blood pressure is like 100/70. Their heart rate's kind of high. It's like 100, but it's not like crazy high. Like, so that's what I would just call, I would call that stable at that point. But if they're stable and there's peritonitis, again, you do a laparotomy, because a peritonitis on the exam is confirming that there is fluid leaking, and that's what's causing those symptoms. So rebound and guarding typically don't happen unless there's fluid that's leaked out of the bowel. And then again, the difference here now is if you do a fast, so the next step would be a fast exam, you do that, and then there is free fluid. Since they're stable, you know you can get a better scan. If they're unstable, you take them to the OR, but if there's free fluid, you can get a scan, a CT, because you know that, well, if they're stable, I can at least see where the fluid is. It'll kind of guide your management in terms of how you do the surgery, where you want to operate, so it'll sort of guide what you're going to do a little bit better than if you just went in after a fast exam. And then the only difference here with I'm not sure if there's free fluid or if there isn't any free fluid, is you can choose between a CT or serial exams, which is just repeated, we'll check on you and do repeated exams every hour. And so if they make you pick between the two of those, I would say, look for something that seems really, really suspicious. Like if they start to give you bigger hints, like there's some localized abdominal pain in some quadrant. There's the signs where there's hematomas on your body, like I forget the names of them. The periumbilical, it starts with a C. I can't remember the guy's name. But the signs where there's hematoma on the skin tells you there's something happening internally. If there's guarding or other things like that, that might hint that there's something else going on, then I would probably do another scan. You might have missed it with the fast. Hopefully that makes sense. I know that these are frustrating and don't mean to pick on anybody who said B or C, because I think those are reasonable, but go ahead and move on. Say this next one, a 25-year-old male arrives in the trauma bay with a gunshot, this time to the thigh, which is bleeding profusely. He received IV fluids in the field and is currently unconscious. Vitals include a heart rate of 85/50. Wow, that's wrong. Blood pressure over 85/50. Heart rate of 140 with cool extremities. Distal extremity pulses are present in the affected limb. And so in addition to early definitive control of the bleeding, which the following is the best next step in management. So we have observation again, we have continued IV fluids, we have administration of FFP, RBCs, and platelets, we have erythropoietin, and then we had straight up amputation. Any guesses? I see a C, yeah. Good work, that was the C. So we'll get to, I think I have something on the next slide, so good, I think everybody got that one. So the whole point of that one, I think all of these have a purpose, basically. And so the purpose is just to talk about the massive transfusion protocol. So if you just keep giving somebody fluids and they've lost a lot of blood, you start to replace blood with just water, water with solutes in it. And your blood obviously has a lot more than solutes. So FFP helps you coagulate normally. RBCs help obviously take oxygen to your body, and platelets also help with sort of normal vascular damage. So if you don't give them what mimics normal blood, you can have dilutional coagulopathy because you don't have the clotting factors. You can have clotting problems just because there's not platelets, and you can also cause them to get really cold just because IV fluids are typically colder. So the way that I think UWorld teaches it is if you have two of the four, which to me are the same things as what I call unstable. It's if systolic is less than 90, pulse is greater than 120. If you have a positive fast exam, which that tells you that there is leakage of fluid somewhere in their abdomen, or if you have a penetrating trauma. So if we think back to the example in this specific question, we know that the blood pressure was less than 90. We know that the pulse was more than 120. So we already feel good about doing MTP, especially if they've already gotten a handful of fluids. But in addition, it was a gunshot wound this time. So penetrating indicates that you know for a fact that there is a place they could be leaking from. And so you say that's another reason why they should get massive transfusion protocol. Does that make sense? You got it all right. So I'm assuming you got that down. Okay. Okay. So we have a 30-year-old female with a history of Marfan syndrome presenting for sharp chest pain radiating to the back. She's in pain but currently stable. And so in this case, which would you do as the best next step in management? For those of you who have seen the IM one, maybe have a little bit of a cheat code, but that's okay. The first one we have is a chest x-ray, surgery, reassurance, ECG, or sedation and intubation. And we can talk about why, because I think a lot of these are good answers depending on the situation. Okay, I see an A. D or A? Yeah, I think both of those are good choices. Another A, yeah. So the idea with this one, well, first of all, the diagnosis, sharp chest pain radiating to the back in a Marfan syndrome patient was supposed to be an aortic dissection. And so the answer I was going for was chest x-ray. And before I explain, let's get to the next part. So the next part is there's a two-part to this question. So the same patient with the same situation, you got a chest x-ray, and now there's a widened mediastinum. So now it's asking, instead of what do you do scan-wise, what do you do in terms of management? So you have a TEE, you have surgery, reassurance, CT angiography, or an ECG. So you've sort of identified there's a widened mediastinum, and so now what do you need to do next? I see a D. Yeah, that's what I was going for in this one. B or D, yep. So Antonio, you're right, but we'll get to it in a second. So D in this case, and then we'll talk about the reason. I put this in both reviews because I think it's super high yield, because on both IM and surgery, they love to ask you which scan to get in which order, and then what you do after you get the scans. This, like any iteration of this question could be on there. So I made it a little steps in diagnosis thing. So the first thing you do in somebody who obviously sounds like a dissection is a chest x-ray. It's cheap, it's quick, and you can see if there's a widened mediastinum, which is like sensitive, meaning that you can, if it's not there, you can just rule it out. But if it is there, you need to confirm it. And so we got the widened mediastinum, and so we know, okay, we at least offered the patient a cheap test, and now we can confirm. And you do a CT angiography because it basically shows you the vessels clearly, and a dissection will appear. You'll be able to see the gap in the wall with the CTA. And so TE is the only tricky one. So if you remember from the trauma bay, that TEs can be done on the bed that they're currently in, and you don't have to move them to the scanner. And so in certain situations, you can do a TEE instead. So I would say CTA is the primary method, but a TE could be the backup to that. And so those are, again, hemodynamically unstable. You basically can't move them to the scanner without hurting them, like their neck is unstable or whatever the case may be. Renal insufficiency, remember you need contrast for a CTA, and the kidneys can't handle it if they have kidney problems, or if you know already that they can't handle the contrast you've given them, like they have a reported allergy. If they give you any big hint like that, I would choose an echo instead. And then once you've done that, once you've confirmed it either with a CTA or an echo, you then, based on the type of dissection, you either do surgery, which is what this rotation is about, or you don't do surgery, which a lot of the surgery rotation is when do you do or not do surgery. So A is if anything, if there's basically any involvement in the ascending aorta, or if there's any symptom that tells you that there's an involvement of the ascending aorta, which would be like, basically, if you think about the three great veins, if it's affecting those veins, it's likely including the ascending aorta. So if they have like decreased perfusion pressures in their arm, or the pressures differ between their arms, if they're having like stroke-like symptoms from the carotids not perfusing the brain, any sort of hint or direct like mention of ascending aorta, you just say OR surgery is the choice. But if they don't, or if there's no symptoms, or if they tell you for sure it's only the descending aorta, then you give them a beta blocker to help reduce the vessel stress. So labetalol or esmolol are usually the right answers. So this, I would say this part is also super high yield specifically for the surgery shelf. Just remember the different ways that the dissection can extend. Can you guys see my mouse, by the way, if I point with it? Okay. So if you think about right and left arms, so if you have the two subclavians here, obviously this is the brachiocephalic, but depending on where the dissection extends, if it stops here, all the pressure will build up on this side and won't be able to extend to this side. So you could have differences in pressures between the arms. You could have the same thing if it's here and you have both arms that are high and the legs that are low. Or you can have it basically rupture out of the aorta into the lungs and cause a pleural effusion, or into the pericardium and cause tamponade, or you can have it stretch the aortic valve. So just think about, if you see it looks like a dissection and then there's something that happened and made it complicated, think about, picture in your head this sort of like the extension of the aorta going down, and think about all the vessels that come off of the aorta, including the renal arteries. You can have renal infarcts from dissections, you can have hepatic emboli and infarcts. So just keep in mind that all of these major vessels come off of the aorta. and it'll probably help you on a weird question like that. That sound good? Okay, so moving on to the differential diagnosis section. So again, this is sort of a read my mind section. So just like shout stuff out, or you can keep the chat has been really working. So you can do the whole chat thing. But when you think of like pelvic injuries, you know how there's like the few types they want to differentiate. What are some of the various types of pelvic injuries you can get? Mm-hmm. Open book, bladder rupture. Mm-hmm. Urethral injury. Yep. Yep. There's obviously more, and this list is not comprehensive, but you guys got everything I put, so I'm just going to move on. So bladder injury, hopefully you can appreciate my very not artistic drawing. So they want you to split it up between extra and intraperitoneal. So these are the two arrows here. So if you think about anterior, so if you have a rupture here versus if it's at the dome. So the anterior of the bladder, basically there's a bunch of fascia here that is separating it from the peritoneal cavity. So if you think about this is the pubic bone, right? The pubic symphysis. If this gets shoved back into the bladder and you rupture at the anterior portion, all of the blood is going to be trapped, and blood and urine is going to be trapped in this specific subregion. So you'll have basically suprapubic like tenderness, maybe a hematoma, maybe blood in the urethra, but you won't have the symptoms you'll have with the dome rupture. So if the dome is directly connected to the peritoneal cavity, so if you rupture at the dome, if they say, oh, there's rebound tenderness, there's guarding, they have referred pain to their shoulder, all these signs that are telling you there's irritation of the peritoneum, you know the dome was ruptured because it's the only part of the bladder that's connected here, as well as it's weak. You see how it's not stabilized by anything. So it's like if you get hit in the front, it can sometimes push all the weight to the top in the dome and it ruptures at the dome. So just differentiate in your head peritoneal symptoms versus just sort of local bladder and blood sort of symptoms. So that's the bladder injuries. And then urethral, I always like to think, so urethral posterior is here in blue and anterior is here in green. So they say pelvic fracture causes posterior. So if you think about this pubic symphysis, if somebody got hit with a car, but it was in a car and they had this pelvic fracture that shoved I just think of the pubic symphysis being shoved directly back, you basically damage only the posterior urethra. So this is the prostate right here. And so it causes all of the trauma and blood that fills up this little space, causes the prostate to be like high riding is what they call it. Whereas if you think about this situation, so this is what's called a straddle injury. If you think about like this specific location, instead of it affecting the prostate, it'll be just around the perineal area. And so you'll have tenderness and a hematoma. And so that's how you can differentiate the two of those types of injuries based on what kind of injury you have and as well as what the symptoms look like. But keep in mind that the urethra, if there's blood in it, there will be blood at the urethral meatus in both situations. So don't confuse that and think that, oh, there's blood, it's got to be one or the other. That's a non-specific symptom. So that'll be in either case. And they usually almost always want you to start with the retrograde urethrogram. You just look up into the urethra. You can visualize if there is trauma. And if not, you can go further and examine the bladder, which is called a retrograde cystogram, or which in most cases you would want to do if you know that it's not urethral damage. And then from there, if you've ruled that out, you know it's something else, but you at least do that in a suspected urethral or bladder injury. Hopefully that makes sense. I tried to bold or put on the slides the only things that differentiated and left everything off because everything else is kind of vague and muddy. Okay, so we'll move on to the next one. Y'all remember the high yield neurovascular injuries of the arm, the random nerves that they always ask you about? And where? I want to shout out a couple. Supracondylar fracture, compartment syndrome, and then shoulder dislocation, axillary. Yeah, those are both good. I don't think I included the a couple of those things, but those are really good. Mid-humerus radial nerve. Yep. Okay. good. So I made a little picture here again with little colorful X's to help you keep it straight. So the axillary nerve is right here around the surgical neck. So if there's an injury to the surgical neck or a dislocation, like somebody said, which is a good point, you damage the axillary nerve. And so the axillary nerve helps you do this. If you think about what the deltoid does. So if you damage that nerve, your arm will just be sort of stuck here. And if you dislocate, obviously, you're also going to see flattening or different shapes and changes of the shoulder, depending on if it's an anterior dislocation or a posterior dislocation. The radial nerve wraps right here around the back of the humerus, and the closest it comes, it runs in the deep spiral groove. So if you fracture the midshaft, you damage the radial nerve. You can also get that happens if you do the sleep at night. If you sleep on the armchair and you rest the back of your arm on a chair overnight, and you basically wake up with inability to probably extend the elbow, but then the other thing is the wrist too. You can't extend the wrist. I didn't put that on this slide. I should have. So you'll get the wrist drop. And then the other one is the median nerve. So it's right at the supracondylar portion of the humerus. So if somebody falls and lands and all the force transmits right here to the lower part of the humerus, then it's the median nerve. And if you think about what the median nerve does, it's the carpal tunnel stuff. So the first three fingers. So think of the first three fingers when you think of median nerve injury. And then ulnar injury. So somebody who falls on their elbow or a bullet, or they got hit with a baseball bat or something in the little bony part of the elbow that sticks out, the medial epicondyle. And it's the exact opposite of the median nerve. It's the last two fingers that get damaged. So you can easily tell the difference because it'll be these three fingers or these two fingers. Just remember the actual name of the part of the humerus, because they'll probably say it if they're going to give you that. Avascular necrosis. Yeah, we'll get to that in a second. Let's see. Is there anything else you guys talked about? Yeah, and keep in mind that these fractures can cause a lot of swelling in a specific location. And if they block the venous outflow, you can get compartment syndrome as well. So that's a good point. I didn't put that in here. Also keep in mind the different types of shoulder dislocations. So I didn't put a picture on here, but if you think about, if I have my shoulder like this and someone hits me from the back, the shoulder will dislocate anteriorly. And so my arm is basically stuck in sort of this like externally rotated abducted position. Whereas if somebody hits me from the anterior side, which is really hard to do, if somebody hits me in the front of the shoulder so hard and it dislocates posteriorly, my arm is going to be internally rotated and it's kind of like tucked in a cast. So remember those two positions, but just picture the injury and you'll be able to picture what happens with the actual like positioning of the arm after the dislocation. Okay, good. Totally changing gears. So acute biliary conditions, which is a huge umbrella, but I just had a very specific set of things I wanted to cover. So you guys want to shout out some stuff that happens acutely with the gallbladder? Yep, biliary colic, acute cholecystitis. Ascending cholangitis. It's almost like you guys read the slide. Cholelithiasis, choledocholithiasis. Yep. Perfect. Pancreatitis from a stone. Yep. I didn't cover all of those, so the slide would be even busier than it already is. So I'll move on, but I'll try and cover what you guys talked about in the chat if it's not on the slide. So by now you probably realize I'm very visual. So I always like to have a picture, and then I like to picture what the organ looks like whenever I think of stuff. So biliary colic is easy because all that happens is a stone gets lodged in the cystic duct for a period of time. Then once the contraction is done and it closes on the stone, it relaxes after you eat your fatty meal, it relaxes the stone back and the pain goes away. So it's like, oh, that really hurt, it's gone. And so the treatment is elective cholecystectomy. So they need one, but there's no rush because they're not currently acutely ill. They just had a problem for a second. So they probably will get one eventually. So acute cholecystitis with a stone, right upper quadrant pain, but then fever and inflammation. So if you block the gallbladder completely and bacteria basically have no way to get out, which this is normally sort of a continually flowing path, now you cause inflammation and infection, and that's what causes the acute cholecystitis. Because that's an acute infection at that point and the stone is stuck, you have to do surgery, as you've seen a million times on surgery probably. So you need a cholecystectomy within 72 hours. A calculus is exactly like it sounds, A without a stone calculus. So these are typically ICU patients. They either eat so little or are so ill that their biliary tract isn't flushing things out like it normally does. So there's no stones, but there's still an infection. And so the difference is you do antibiotics, but you do the cholecystostomy tube, which some of you probably saw. So that's where you physically put in a tube from the outside and drain it. And that's assuming that they were so ill that you can't treat them with surgery. So you need to just drain it. Then eventually you can do surgery if they do stabilize. Emphysematous is exactly like it sounds. Emphysema when there's air. So it looks like cholecystitis, but there's crepitus because you push and you feel the air when you push or you hear it. So there's crepitus and then air fluid levels on a scan. So that's basically you visualize that there's bubbles of air in the gallbladder. So this, because it's caused by anaerobic bacteria from the gut, you need anaerobe coverage. So just keep that in mind if they ask you the specific coverage. I hope they don't, but keep in mind like metronidazole or ampicillin sulbactam, something that covers anaerobes. And then acute cholangitis, that's the very different one from basically the rest of these so far. So that's when a stone is in the common bile duct. And so so previously we've only obstructed the gallbladder. So the rest of the bile and what's the word I'm looking for? Bilirubin is able to flow out like it normally does. But in choledocholithiasis, you block the ability for bile to flow out. And so now you have bilirubin buildup, which causes jaundice. But acute cholangitis is an infection of that stone. So it's basically takes it a step further and you add fever to that. And so you need to do antibiotics for this because it's an infection, but you also need to do ERCP drainage where you go in through the duodenum, go up the biliary tract and pull out the stone. Because if you did a cholecystectomy, you wouldn't get the stone because it's not in the bile duct, it's not in the cystic duct and it's not in the gallbladder. So the way I always like to split these up is if there's fever and leukocytosis, then it's one of the two infections. It's either cholecystitis or cholangitis. And then you basically differentiate the things that are in the gallbladder from the things that are in the common bile duct based on the bilirubin levels. If they're jaundice, if the bili is elevated, if their AST and ALT get super high, that's how you can separate those two. That makes sense? Does that sound good? Any questions? Just want to make sure I didn't just cover it in a way that doesn't make sense. Okay. Let me know if there are, or just put it in the chat and hopefully I'll see it. Okay. Move on. So you want to briefly just mention the types of shock, like you don't know these, but just put a couple in the chat and I'll. Hypovolemic, cardiogenic, obstructive. Yep. So neurogenic. Yep, that's good. So I made this fairly busy slide and I'm not going to put like all of the arrows. You know how the arrows go up and down. I think you've reviewed those plenty, but I wanted to talk about the sort of primary problem and then just other hints, and then we can move on. So, and there's a picture on the next slide that'll make it make sense. So we'll just talk about this briefly. So hypovolemic, you either some sort of leak of fluid, whether that's blood or dehydration, there's less fluid than there should be. So the primary feature is decreased preload or PCWP, which is pulmonary capillary wedge pressure, which is just a measure for what's happening in the atria. So that's code for the same thing. But keep in mind that other hints include increased ejection fraction, but a decreased cardiac index. And that I thought that seemed super confusing. But if you think about it, if your body needs to pump blood like it normally does, and you're short on blood, your heart's going to contract and eject more of the fraction than it normally does. But cardiac index is a measure for actually how much the blood the heart is putting out. And so if you literally have low fluid or low blood, you'll have a decreased cardiac index, but an increased ejection fraction. It's telling you that you're low on blood, but your heart's working harder to get what it does have out to the rest of your body. So keep that in mind. Don't confuse those two things. They're a little bit different. Cardiogenic is pretty simple. It's just an acute problem with the left heart. So the primary feature is decreased cardiac output. Differentiate that from obstructive. Obstructive is basically either blockage at the lungs, a pulmonary embolism, or tamponade that's obstructing the entirety of the heart. So it also has decreased cardiac output, but differentiate these two, which we'll show a picture on the next slide. Cardiogenic happens when the left heart can't get things out, And obstructive typically is happening when the right heart can't get things out, but we'll show a picture of the difference there. So keep that in mind. The lungs will be affected in cardiogenic in terms of the lungs show up, like there's pulmonary edema, coughing, like the symptoms that you would expect if there's fluid backed up in the lungs. And then distributive, I saw somebody put neurogenic and septic. Those are both considered distributive. They're just a little bit different. But the primary problem with those is decreased afterload. So now we have a primary problem that's different pretty much between all these three. But the warm extremities is a big hint for distributive. So the next slide, we can talk about the why. Hopefully it makes sense. So another picture here. So if we start with hypovolemic, so if you think about it, so decreased preload or decreased PCWP. So let's just say somebody pokes a hole in all of the veins that return the blood to the heart. You now have less blood, so your preload is decreased. What's coming back to the heart is decreased. And so you can sort of reason through the rest of it from there. It's just important to remember what the primary finding is. Cardiogenic, if an MI happened or something, the left heart can't pump the blood to the rest of the body. So that's the primary problem, is decreased cardiac output, but all of the blood that is stuck here backs up into the rest of the heart. So you'll have some overflow of the right atrium, the lungs will be full, there'll be coughing, pulmonary edema, and so on. There'll be edematous, so on and so forth, just like an acute CHF episode. Obstructive, so if there was a massive PE, or if the tamponade was compressing the heart so much the blood couldn't flow from the lungs back into the heart, you'll have similar findings to cardiogenic, except you will exclude the lungs because the blood is backing up from the lungs to the right heart. So it'll be the right heart exclusively that has the symptoms. And then, so distributive includes neurogenic, anaphylactic, and septic shock. So if you think about the primary problem, it's afterload, so arterial problems. So in sepsis, the bacterial toxins basically damage the blood vessels and cause it to leak all of your fluid out into your body. In anaphylaxis, it's the similar thing. So an allergen causes a reaction where you basically, it's the same thing, but different in terms of it's the same the problem is primarily just widespread vasodilation, but it's just not the same cause as sepsis. And then the last one is neurogenic. So if you think about your spinal cord and your brain always are regulating the pressure of your arteries. So if you have a massive spinal cord injury or a massive head injury and you can't control the tone of your blood vessels, they all vasodilate and pool. So it's all the same thing that's happening, but just think about those three different syndromes. They're slightly different, obviously. Hopefully that made sense. Cool. That's all I have for that one. Okay. So what do we remember about lower extremity vascular disorders? For those of you on vascular surgery, there's like too many to count, but we'll focus on the ones that are important for tests. Yep. Peripheral artery disease, DVTs, chronic venous insufficiency, yep. Acute limb ischemia, yep, that's good. Compartment syndrome, yeah, those are good. I mostly had diabetic foot ulcers. I mostly have chronic things on here, so the acute ones are really good, but I didn't put them on this slide. But I can maybe touch on them if I remember to, but before the slide is over. Okay, good. So we'll move on. And so I just put the ones that I found super high yield. So this is, again, another overlap between internal medicine and surgery. They love ulcers on both of the shelves. They love them. So I split it up into location and then other hints. So PAD, arterial flow goes to basically it's pumping blood to the distal portions of your feet. And so the furthest part from the heart is, if there's arteries that are constantly clogged, the thing that's furthest from the heart is what's going to get the least blood flow. So that's why you get symptoms at the tip of your toes. That's why if you lay down at night, instead of being seated, you're flat, you get night pain. And then history of ACS, or if they say their lipids are off the charts or something, you'll get claudication when you walk. All those things tell you that it's PAD. So just try and start with the location. And then if you need more hints than just, if they don't give you the location, look for the other things they give you. So chronic venous insufficiency historically is the medial malleolus, right? That's the high yield buzzword, because if you think about what the veins are doing there, the valves are closing and the blood is coming back up, but but if your veins are insufficient, the blood pools at your ankles. And so it's usually right around the bony parts of your medial malleolus. And then hyperpigmentation when the blood leaks out, and then history of chronic. So it's like that person who's been standing up all day for their entire career. That's like those kind of people that it shows up on the exams. And then diabetic foot ulcers is a totally different location. So it's the sole of your first metatarsal. So when you walk, most of the pressure is on the first and second metatarsals. That's just how people typically walk. You sort of walk with the striking gait. And so if someone has severe neuropathy and they can't feel their foot, then when you walk, the place that takes the most pressure, typically a normal person who doesn't have neuropathy would be able to feel and know basically how to not strike hard enough, or whatever the case, would feel if there was damage. But if someone with severe neuropathy has this problem, the wound gets worse and worse and worse until there's an ulcer. And another hint is that it's going to be painless, right? Because the neuropathy is so severe that they're having an ulcer. It's probably painless, because in a person without neuropathy, it would hurt a lot if you had an ulcer that was on the place you walk for every single step. And then the last two I think are high yield, but probably more for step 2 than a shelf thing. So superficial thrombophlebitis is basically when the veins are either swollen from a malignancy or like an infection. So it's superficial veins. If you think about it, you can sometimes see superficial veins on your skin. If you acutely clotted one of those, you would have like sort of like a really thick looking vein on your skin. That's what it looks like. Whereas lymphangiitis is exactly what it sounds like. It's itis is the inflammation along the lymph. And so it's flat streaks. It's like if someone like put your fingernail on your arm and you have a red streak, it looks like a flat red streak. So in people with like the sporothrix, the like high yield fungal infection, or like cellulitis erysipelas, if there's an infection tracking backwards along the lymph, that's what it looks like. So I would differentiate those two based on what they look like as well. But keep in mind that superficial thrombophlebitis can have really high yield associations like GI cancer or the Berger syndrome, which it has the basically fingertip necrosis. What's the migratory superficial thrombophlebitis a clue for again? I can't remember. Yeah, so that's that is for typically pancreatic cancer, but it can technically be any GI cancer, I think. So if they say, if they give you any cancer hint or cancer choice, I would pick that. I think everybody talks about pancreatic, but I've heard that it can be other types as well. So acute limb ischemia, that's a good one. I'm just reading the chat now. So acute limb ischemia, keep in mind that if you have an emboli, like if you had a MI, or if someone has atrial fibrillation, remember that the heart is constantly not pumping the blood in the order that it should. So if that blood is static for any amount of time, that's a risk for a clot. And so all of the blood is connected. So you can have blood thrombose or embolize to the brain and cause a stroke. You can have it embolize somewhere else. You can have it embolize to your leg and cause acute limb ischemia. So it's kind of like the aortic dissection. All the blood vessels are connected. So if there's a problem somewhere that's sending a problem distally, you can technically have an infarction or an emboli of any part of your body. And then Antonio, you said compartment syndrome. That's a good point. So make sure to differentiate compartment syndrome from acute limb ischemia based on what's actually happening. So compartment syndrome, I think of it as a problem where you can't get the blood out to come back. Acute limb ischemia is where you can't get the blood in the first place. So acute limb ischemia, you don't get the blood to your leg. It's cold, it's white, it's like mottled, and because you're not getting the blood into the foot. Whereas if I have compartment syndrome of my foot, I can't get the blood out. So it'll be the exact opposite. It'll be swollen, it'll be warm, it'll be red, so on and so forth. So they look similar in that they're acute, but they're like totally opposite in the way that the blood is flowing in. Okay. Would be that point to death. Okay, I think we're almost to the end of the differential diagnosis, and then we'll finish up with rapid review. So spinal cord injuries, I should say the high yield sort of buzzword, spinal cord injuries. Any that come to mind? Anterior. Anterior spinal artery is a good one. Cauda equina syndrome. Oh man, that one has got me for years. I hate that one. Syringomyelia. Yep, that's a good one. I'm glad you said syringomyelia. I have a point I want to make on the next slide. Central cord syndrome. Okay, good, nice job. Brown-Séquard, yep. I swear you guys are like reading the slide. Okay, so pardon my drawings. I will try and make sense of what I drew. So a complete transection is basically if you just think about what the spinal cord looks like. So this is a cross section of the spinal cord. So if you just think of someone just taking a knife straight through everything, both sides is going to be weak and damaged. So there'll be bilateral weakness and sensory loss, but it'll only be below the lesion because the spinal cord is basically supplying branches at each section of the spinal cord. So if you have it at L2, it'll be everything below that. If you have it at T1, you'll probably have the arms and the leg, or you'll probably just have the torso and the legs. But if you have a cervical, it'll probably be arms and legs. So just keep the level in mind. But that one's not hard, so we won't spend time on that. Brown-Séquard, if we look at the blue, so I try to do the blue color with the X. So this isn't the best picture, but if you remember, there's the posterior columns, there's the lateral cortical spinal tracts, and then there's the spinal thalamic tract up here. So just keep those three tracts in mind, and we'll talk about what happens. So if you do a cross section through half of it, you damage the posterior column, you damage the cortical spinal tract and the spinal thalamic. So you damage all three. The only difference is that this is obviously a minutia detail, but if you remember, the spinal thalamic tract crosses in the spinal cord before it ascends back up to the brain. All of the other tracts in the body ascend to the brain and then they cross over. So long story short, you'll have same side weakness, same side normal sensory loss, but then you'll have opposite pain and temperature. So it's like that, if you've seen the UWorld picture with the colors on the different legs, that's what it ends up looking like. Hopefully that makes sense. I feel like if that's something you remember, it does make sense. And if not, it's super confusing. So central cord syndrome, I drew here with this black X. So I wish I can erase it now, but there's basically a little central cord that is typically empty that runs through the spinal cord. So if the classic injury is if there's an old person in a car wreck who whiplashes, you basically extend your neck so hard and so fast that this central cord fills up with either fluid or blood or something. And if you think of the arrows are drawn to picture an expanding sort of mass here, then you start to damage all of the same tracts. So it'll be bilateral, but because it's usually the neck, it'll usually just be the arms, which is exactly what single syringomyelia does, except it's not traumatic. So I've always thought of central cord syndrome as traumatic syringomyelia because they look the exact same. They're just pain and temperature loss and sort of weakness maybe of your hands and fingers, but your legs are probably almost always fine. And then anterior cord syndrome would be a little bit, it's the red X's here. It would be a little bit easier if this picture had the anterior spinal arteries, but keep in mind, there are arteries that supply our spinal cord. So the anterior, it looks like a V. The anterior arteries supply the front 2/3 and the posterior supplies the back 1/3. So if you have a burst fracture of the vertebrae, and if you see my mouse right here, if you have a fracture of the vertebrae and it hits the spinal artery that runs right here in the front, you damage the front 2/3. Or if you have, that, I forget the name of that weird artery, but the surgical syndrome where you basically don't perfuse the spinal cord well, you have a watershed infarct because it's this huge connecting branch. Either way, the symptoms are bilateral, but the only thing that's spared is this here in the back, the posterior columns. So you'll lose everything bilaterally except for normal sensation. So your ability to feel yourself touching something, vibration if someone put a tuning fork on your hands or feet, proprioception, so if someone closed your eyes and had you do this, that will all be spared, but everything else will be damaged. So you'll have weakness bilaterally, you'll have pain and temperature loss bilaterally. So again, it all goes back to the tract that's affected, but if you just want to memorize the syndrome, I think that's fine. I think that'll get you through the exam if the tracks are too complicated. Yes, yeah, artery of Adamkiewicz, that's exactly what it is. Like some ridiculous name for some guy who found it originally, of course. Do those make sense? I know that if the tracks are confusing, then that's a whole different rabbit hole, but hopefully that does make sense. If nothing else, I vote for memorizing the syndromes because these are probably the 4 that'll come up. Okay, so we'll do some rapid review here, and I'll keep the chat up so you can just feel free to chime in the chat. So These will be really quick. So recent chest trauma, paradoxical movement of the chest when breathing. Yep, flail chest. So I just put in parentheses 3 continuous ribs. I should have put a picture. So it's basically if you create a square where you basically cut out a square of the ribs. If you've ever seen a picture, it's kind of interesting. But the reason it's paradoxical movement is because normally I breathe in and my chest expands. I breathe out and it closes. But if my ribs aren't connected to my chest, then when I inhale, there's a decrease in the pressure in my chest, and that decrease causes those ribs to move inwards, whereas they normally expand because my chest is filling with air. So it's all related to the fact that the ribs aren't attached to the chest anymore. Anyway, someone talked about this earlier, but fall on an outstretched hand, and now they have pain in the anatomical snuff box, but weirdly enough, the x-ray was normal. Yep. Scaphoid fracture, and exactly. So the reason that's important, so let's look at the answer. So scaphoid fracture, non-displaced, you do the cast. So it's that long cast that holds your thumb like this for like 6 weeks. But if it is displaced, you want to do surgery because it's not going to just move back into its own position on its own. That's true. I think when I started surgery, I was super confused about when to do surgery for bone stuff, when to not. And I think on these NBME exams, if they ever say displaced, or if it looks super displaced to you, that's them telling you to do surgery, because the bones don't move back to where they originally went to unless you put them there. But if it's fractured and they're still exactly where it was, then you usually don't need to do surgery. That's the simple way I kept it. Somebody who's doing ortho is going to disagree with me, but that works on exams. So it works for me. The thing with the non-displaced, you need to do serial x-rays because exactly someone said the avascular necrosis. So it doesn't show up originally on the x-ray a large portion of the time. So you have to have them come back next week and do another x-ray. So choose the choice that says a cast and a serial x-rays, or repeat the x-ray or something like that. Elderly patient with a history of alcoholism now has head trauma and altered mental status. Kind of vague. It could be any number of things, but I try to throw in some buzzwords. Yeah, subdural and then subarachnoid. So we can talk about that. So what I was going for was subdural. Oh, okay. Anyways, I was going to explain both, but it was just a typo. That's fine. Subdural hematoma. So the bridging veins get sheared. And so the reason elderly and alcohol is important is because elderly patients usually have shrinkage of their brain, and same with patients who have chronic alcoholism. So when the brain shrinks, the veins don't shrink. So now there's this long gap between the brain and the vein. And so it's more likely to be cut. It's just like a string being pulled tighter. So the more the brain shrinks, the more likely it is to tear. It can be kind of subtle if they've had it chronic subdural, but anyways. High-speed motor vehicle collision. And now they have upper extremity hypertension and a hoarse voice. Almost seems super unrelated, but if you've seen this question, you may already know how to figure this one out. Any thoughts? Okay, so what this was going for was traumatic aortic rupture. And this goes back to what I said about dissections. So if you think about the aorta, it's connected to a ton of different things. So if you picture the aorta right here, at the point where it starts to descend is where it's basically connected. I think it's the ligamentum arteriosum, the thing that was the ductus arteriosus, is connecting it to the pulmonary arteries. So if you have a really severe impact from a car accident, you basically rip that part of the aorta. So upper extremity hypertension, because all of the blood gets stuck in the arms and can't descend down. And then a hoarse voice because the recurrent laryngeal nerve wraps around the aorta right there. Yep. And so it wraps around at the exact spot that you tore it. And so they might have problems moving their vocal cords. So the reason I put this on here is because it seems like unrelated symptoms, but just anatomy will help you get through those. Blunt trauma plus left-sided chest pain, and then you do like an NG tube, and it's not in the abdomen. And you may see something similar to this on peds. Yep, diaphragm rupture. Yep. So that's always the trick, right? If you put an NG tube down, and assuming you did it right, and you didn't put it somewhere else, if you put an NG tube down and it's not in the abdominal cavity, it's because the bowels and the GI tract is somewhere else. And usually that's because there was trauma that ruptured the diaphragm. It usually happens on the left because the liver usually provides some protection on the right. And so it's usually left, and you'll see, you might even hear, like, the congenital diaphragmatic hernia. You might put your stethoscope here and you hear bowel sounds. You'll see the tube coil in the upper left chest cavity, so on and so forth. But in most cases, I think they need surgery. A pediatric trauma patient, but 24 hours ago, and new onset epigastric pain and vomiting. Seems kind of weird, right? Usually, if they're going to have trauma, they're going to be having problems immediately. Yep, got it, Carly. Duodenal hematoma. So when you have trauma, most of the time, the trauma causes the problem immediately. But with duodenal hematomas, it takes time for the vessels to leak enough blood out. You basically have to obstruct the entire duodenum to have this vomiting happen. It's like if you think about biliary atresia, so I'm making a ton of peds parallels here. So if you think about biliary atresia, the bowel never canalized, so you just vomit. But in the case of a hematoma, it has to get big enough to obstruct your duodenum. So that takes a little while. That's how I think why it takes 24 hours. Whether or not that's true, someone else can confirm or deny, but that's what I use. And then last one on this slide, head trauma, brief loss of consciousness, now has headache, nausea, and vomiting. This was kind of vague. I could have worded this better. Yeah, epidural, okay. Nice. So epidural, rupture of the middle meningeal artery. If someone knows the answer, I actually am not 100% sure why they have a brief loss of consciousness, but that's a super big, like, whatever buzzword. Whether it happens a lot, I don't know. But epidural, middle meningeal artery right here at the pterion, basically where your temples are, is super subtle or super sensitive to damage. So if someone gets blasted with a baseball or hits a car or falls and hits right here, where all of the sutures connect, that's a weak point, and epidural. So again, subdurals will have the crescent looking shape. Epidurals will be trapped between the sutures because that's the problem that happened in the first place. So it'll be a convex, basically the convex looking appearance of the blood. Let's see if there's anything else super high yield about those. I think that's mostly it. We got a little bit more, I'll go faster. So pancreatic surgery, new onset anion gap, non-anion gap metabolic acidosis. Super non-specific. I think I remember seeing this and being like, what? There's like nothing happening. They may not even have any sort of pain. It may just be like kind of a weird acidosis syndrome. Okay, I'll just click. So that's pancreatic fistula. So if you have pancreatic surgery or any problem with the pancreas, right, is sending bicarb into your duodenum. So if you block it or the surgery leaks, basically, if there's any problem with the surgery, all of the bicarb that's being created dumps into your abdominal cavity. And so now, instead of it being sort of getting into your bowel and into your bloodstream like it normally does, you're dumping all. Imagine if you just poured your body's bicarb out the door, you're going to have an anion or a non-anion gap metabolic acidosis. So that can be a tricky one. So if you think about, like, if somebody had a Whipple for a pancreatic surgery, that could happen. If someone, I think that could also happen if someone has really bad trauma that causes a pancreatic, can cause a pancreatic fistula or pancreatic trauma. I think that can happen as well. A child with extremity pain, fever, leukocytosis, and then a weird periosteal elevation and some osteolytic lesions on MRI. The reason I asked about this one is for the management, but you guys have any ideas what this is? Giant cell tumor, that's a really good point. So bubble thing, so we can talk about that. So what I was going for in this one was osteomyelitis, but that's just as valid of a guess. So what I was trying to really talk about really was the bone biopsy. So if you do see osteomyelitis in these situations, you need to diagnose it with a bone biopsy to confirm what actual infection you're treating. And so it can be tricky because it can sometimes look like tumors. And I think the biggest tricks are if there's fever and leukocytosis, usually, unless I know that's not always true. Like osteoblastoma, I think, can cause fevers at night. But usually if there's like a really high fever and leukocytosis, it's probably an infection. But then the other thing that they'll sometimes say is like, they'll say bone, what do they say? Like bone marrow edema, or just like edema in the bones, basically indicating that there's like a local infection that's causing swelling in that area. But giant cell tumor is a good one. So that's basically in a young, usually a young female, like right at the knee, and it looks, yeah, like looks like a soap bubble. So definitely a good guess. Let's see. Next one, full thickness extremity burn. Now they have pain on passive stretch and a rapidly increasing swelling of that extremity. This is sort of two things at once. Yep. Yep. So it's a full thickness burn that caused an eschar, and now the eschar got so big that it's causing obstruction. Remember, the veins draining the extremities. If it can't happen, it can cause compartment syndrome. So the trick is that this is one situation where you don't treat compartment syndrome with a fasciotomy, and that's because the fascia isn't the problem. It's the eschar that's the problem. So you get rid of the problem instead of just cutting. So in almost every other situation of compartment syndrome, you do a fasciotomy, but in this one, you do an escharotomy. But you know that. Sudden onset respiratory distress after you remove a central line, but there's also hypoxemia and obstructive shock. And interestingly, they have normal breath sounds. So these last two are tricky, so I'll just sort of talk about them. Oh yeah, or you could just get it right. That's fine. Venous air embolism. Yep. So the idea is that, and then I'll just go ahead and click to the next one so we can talk about the difference. So that versus a pneumothorax can look very, very similar. So if you think about venous air embolisms, it's the air itself is in the veins and in the circulation. So it's obstructing the heart. It's an air bubble so big that it obstructs the right side of the heart. So you get obstructive shock because the right heart can't move to the left, like we talked about earlier, and you removed a central line. So you basically introduced a bit of air into their venous circulation. Whereas a pneumothorax can look similar. It'll cause respiratory distress, which will be pretty similar. But the difference is that air is trapped in your pleural cavity. It's not trapped in the actual veins themselves. So it'll cause JVD, right? Because of your pleura is really close to your major veins. So this will expand, compress the, your, what's it called? Jugular veins, cause JVD. It'll also cause hyperresonance because if you tap on somebody with a bunch of air in their chest, you'll hear the air, but you won't have the symptoms of like hypoxemia and things like, well, you might have hypoxemia, but it will look a little bit different because it's in your pleural cavity versus in your actual heart in the circulation. So keep that in mind. When you differentiate these two, if you see like shortness of breath in a young person that's really acute and you have nothing else to go off of, just think about where the actual air is located to tell yourself the difference. And we have the last few here. Long-standing reflux, severe pain now, rebound guarding, and free air under the diaphragm on on an X-ray. It's like that high yield thing where you see free air and you're like, oh, surgery. So this was, yeah, perf. Regardless of where it is, you need surgery. So it doesn't really matter where it is. But in this case, it was probably a peptic ulcer. Somebody with GERD for 30 years and now has like basically perf. And so just remember to look for that. If they give you a chest X-ray on the surgery shelf, look at the diaphragms on both sides. Make sure you don't see air because that'll be a free question if you do see it. So just keep in mind to look for that. Another tricky one. So recent cardiac cath. Now they have severe abdominal pain and a weird looking rash. If you think of a syndrome that can cause a bunch of different symptoms, yeah, cholesterol emboli. So this is similar to what we talked about earlier, like an AFib. So if you cath somebody and you basically poke off a part of their cholesterol plaque and send it into their circulation, wherever it ends up is where the symptoms are. So in this case, it was probably one of the major mesenteric arteries. And then the libido is basically the superficial circulation of the limbs. If you clot off some of those small arteries, you get the weird lacy looking rash. So keep that in mind. But there's other places that this can happen. So if it goes down to your foot, you can have that blue toe syndrome. You can have acute limb ischemia with this as well. You can just think about renal. You can have renal infarcts. I think is like the most common thing to have with these is renal infarcts. So anything that catches a cholesterol clot can infarct in that case. Older patient with severe abdominal pain, but mild tenderness. And you're like, wait, did I read that right? The pain is so severe, this guy is jumping off the table, but then you push on it and it's mild tenderness. So exactly, acute mesenteric ischemia. So I just put that on here because they probably won't tell you the pain is out of proportion. You have to usually figure that out just by reading kind of the hints that they're giving you. So the pain will be really severe. The physical exam, you'll be like, are you lying? But they're not. It just doesn't present. It's not a physical problem of the gut. It's blood supply. So pushing on it won't necessarily elicit the pain. Right upper quadrant pain radiates to the back. Recently started on thiazides. Or really any drug. There's so many drugs that can cause this. I'll just click because so it's the idea is acute pancreatitis. So thiazides are known to be linked to acute pancreatitis, super rare. And then you're like, what? Right upper quadrant pain? Sometimes just based on the way it refers or based on people's anatomy, it can be the right upper quadrant. So don't be super set on it has to be epigastric pain. Just be flexible with, because sometimes NBMEs are like that. They don't keep in mind that, or they try to make you think like that. And you're like, wait, but that's not where the pancreas is. Anyways. Last two here, and then we'll be done. So postoperative patient with a non-intact fascia. So you can physically see that fascia aren't intact and there's organs potentially either sticking out or you can see them. So it does not sound like a good thing. Basically, this one's just is a little vague. It's basically to tell you that the fascia is not intact. And so the surgery has not closed the way it should. And so you need to do surgery and close that because there's a possibility the bowel can leak out of this gap and then can be ischemic and cut off. And contrast this with this next one. So it's the same thing, it's postoperative patient, but now there's just skin separation, but you remember the residents poking and feeling for fascia. You feel that the fascia is intact, but there's a little bit of fluid. So this is a little bit different. So this is, instead of deep dehiscence, this is just a superficial wound dehiscence, which is like the vast majority of abdominal like surgeries. A lot of them happen like this, especially in older patients who don't heal as well. So you just change the dressings carefully. So just keep in mind, the most important thing is look at the fascia. They'll tell you what to do based on what the fascia is doing. The skin will heal itself, the fascia will not. You have to close the fascia. So I think that's the last thing. And then I threw some substances on here because I remember seeing some, but I will just click through these real quick rather than us doing them. I would definitely do these before the internal medicine shelf though. And if you want to look at them, you can. And that is it. Stop.